Hello, everyone. My name is Aubrey Jones, and on behalf of the National Center for Medical Legal Partnership and our panelists, I would like to thank you for taking time out of your very busy schedules to attend this session. We're very excited to welcome you to part 2 of our Understanding and Addressing the Health-Related Legal Needs of Older Adults and Their Families webinar series. In just a moment, I will turn this presentation over to our panelists. But before that, I have a few housekeeping things that I would like to run through with everyone. Everyone joined on mute. However, we want you to get involved. We strongly encourage you to pose any questions that you may have about this topic in the Q&A function so that our panelists can see them and connect with you. Send a chat to the host and panelists if you need help. To activate captions, select Live Transcript and Show Subtitle. Today's recording and slides will be available to everyone on our website by next week. Give us a little time, and we will put the link in the website in the chat as well. We also want to acknowledge that this project is supported in full by the Health Resources and Services Administration, or HRSA, and that the contents of are those of the authors and do not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the US government. Now to the learning objectives. Today's webinar will explore Medicare and related programs and how they help to reduce healthcare costs for older adults. We'll take a closer look at the Medicare Savings Program and the Extra Help Program and how they play a role in improving affordability. We'll also leave with new, practical strategies to enhance healthcare access and outcomes for vulnerable older adults in your communities. Now let's take a look at who health centers serve. Let's get into the numbers. In 2023, health centers reached a major milestone, serving 32.5 million patients, or about 1 in 10 people in the United States. They provided care to 1 in 5 uninsured individuals, 1 in 3 people serving in poverty, and 1 in 5 rural residents. Federally qualified health centers, also known as FQHCs, also served 3.8 million patients aged 65 and older, including 1.6 million Medicare fee-for-service beneficiaries, resulting in $1.1 billion in Medicare spending on their care. Now, I'm excited to introduce our panel of speakers who bring a deep expertise on today's topic. First, we have Katie McKee, supervising attorney at the Pennsylvania Health Law Project. We have Jessica Lippert, paralegal with the Pennsylvania Health Law Project, and Tia Whitaker, statewide director and outreach and enrollment at the Pennsylvania Association of Community Health Centers. I know we're super excited to get this started, so without further ado, I will pass it on to Katie McKee.
Thanks very much, Aubrey. Thank you so much for having us today and for being here with us. We're really looking forward to talking with you about Medicare and programs that help with Medicare costs and how these programs really benefit low-income Medicare beneficiaries. Next slide, please. So just briefly, before we get started, we wanted to share a little bit about the Pennsylvania Health Law Project. You're hearing from 3 of us here in Pennsylvania. The Pennsylvania Health Law Project is a statewide legal services program in Pennsylvania. We primarily help people with issues related to Medicaid eligibility and access to Medicaid-covered services, but we also do a lot of advising and working with low-income Medicare beneficiaries about the topics that we're speaking about today. Anyone can call our office regardless of income. We work with consumers, family members, other advocates, and providers to help people understand and access Medicaid coverage and services. And because we're a small program, we try to expand our outreach through trainings, consumer education materials, as well as a monthly newsletter with updates about Medicaid and other public health insurance programs. Next slide, please. So to kick things off, we want to hear from you. Please chat in to get started on engaging with us about and let us know where you're joining us from. It's always good to see, on a webinar when you can't see folks, it's always good to see people chatting in and hearing where you're coming from. So thank you to those of you who are chatting in. All right, next slide, please. All right, just a short roadmap of what we'll be covering today. We're going to review to make sure we're all on the same page, a few Medicare basics, and then we're going to dig into the programs that help with Medicare costs. And we'll talk a little bit about people who are dual eligible for both Medicare and Medicaid. And I will turn it over to Jess.
Thank you, Katie. It's exciting to see all of the folks chatting in where they're from. I even see somebody from Hawaii, so that's really exciting. We have another poll question for you before we get started and jump into some of our Medicare information. We're just curious, how familiar are you with Medicare? Are you really familiar? You know the basics, but you're still learning. You've heard of it, but you don't know much, or you're not familiar with Medicare at all. So go ahead and answer that poll question. We're just curious to see where everybody is at before we get started. I was going to say, do we have any answers there or results?
Yes, they're coming in
Okay,
about
perfect.
73% of the
Oh,
way.
wow. Okay, good.
we'll,
Thank you for
yeah,
all participating.
we'll give people about 5 more seconds and then we'll close it out.
All right, well, great. I can see that there are a lot of folks in here who are familiar or know the basics, and then some who are still learning. So I think today, with what you're going to learn, it's going to help give you a very high level overview of Medicare. Again, it's not going to be the in-depth knowledge that you could get with some of the resources that I'm going to provide later, but it'll give that high level overview so that when we move into discussing the assistance programs, you'll see how they will benefit individuals who are on Medicare. So next slide. So let's get into this and let's start talking about who gets Medicare. Who's eligible for Medicare benefits? I think for most individuals, when they think about Medicare, what comes to their mind is typically our older adults. And that is the most common group of individuals that you will see with Medicare benefits, those individuals who've aged into Medicare. So they're 65 years of age or older. But we don't want to forget about the other groups of individuals who are also eligible for Medicare benefits. Individuals who are getting Social Security disability benefits for 2 years. So they're getting those Social Security disability checks. And once that's happened for 24 consecutive months, they become eligible for Medicare benefits. And we also have our individuals who have end-stage renal disease, ESRD. And if they are receiving dialysis or have a kidney transplant, they are also eligible for Medicare benefits. Now, we know about eligibility, who is eligible, but how do you actually get enrolled in Medicare? That can, for some people, be a little bit confusing. The process may be a little confusing, but there's really two ways. For me, the easiest way to describe this to individuals is The automatic enrollment is when Social Security knows about you. So you're receiving some sort of monetary benefit from Social Security. You retired early, maybe at age 62 and started collecting Social Security retirement. They know about you. You're getting a check. They will automatically do that enrollment in Medicare. If you're receiving Social Security disability payments, again, they know about you. They're going to automatically enroll you in Medicare when you are getting close to that eligibility date. And when I say getting close to that eligibility date, that means about 3 months before you become eligible, you would get your Medicare information and your card in the mail. Now, everybody else out there who is not collecting some sort of Social Security benefit, they actually need to do something. So they would need to contact Social Security to do that application for Medicare. And that could be somebody turning 65 and needing to enroll in their Medicare benefits, or somebody, again, who has end-stage renal disease. And usually for those folks, they typically work with social workers at their dialysis center to get that paperwork started. So just remember that. There's 2 ways. If Social Security knows about you, you're getting payments, they're going to automatically do that. Everybody else, they're going to need to apply through Social Security. Next slide, please. So we know now who is eligible, how you enroll, but let's talk about Medicare coverage. And again, the very basics, a really high level overview of what benefits you receive once you are enrolled in Medicare. So Medicare itself, as you can see, we have 4 different parts listed on here under Medicare, but I'm going to focus on the first 2, Part A and Part B, and call that original Medicare. And when I say original Medicare, we always say your red, white, and blue Medicare card. It's a paper card that people get in the mail when they are eligible for those Medicare benefits and have enrolled. So let's start with Part A. Part A is the hospital portion of Medicare. Again, easiest way to think about Part A, think about inpatient coverage. So you're inpatient, you've been admitted to the hospital, or you're in a skilled nursing facility, you're receiving rehabilitation. So maybe that started at the hospital and then you moved on to that skilled nursing facility. Home health can also fall under Part A, as well as hospice coverage. Part B, which is also part of original Medicare, and again, on that red, white, and blue paper card that individuals receive in the mail, Part B is probably what people are going to use on a more of a daily basis. Think of Part B as your outpatient coverage. It's your primary care doctor visits, your specialist visits, when you need to go get blood work done, x-rays, scans, labs. It also includes things like durable medical equipment, so walkers, oxygen, wheelchairs, ambulance coverage, so rides to the emergency room, mental health care coverage, all of those things, again, that people tend to use on a daily basis typically fall under Part B, that medical portion of Medicare. Then we're going to move into the next 2 parts of Medicare, which are a little bit different. So remember, Part A and B are original Medicare. We're going to move into Part C and D. So Part C of Medicare is also known as Medicare Advantage. So I think a lot of people know about Medicare Advantage. I'm sure you see all of the commercials on TV, particularly in the fall during open enrollment about Medicare Advantage. Medicare Advantage plans are private companies that are contracted with Medicare. And if an individual chooses to enroll in a Medicare Advantage plan, they will receive all of their Medicare benefits through that Medicare Advantage plan. So it's going to be almost like call it a one-stop shop. You're going to have your Part A, your Part B, and I know we haven't gotten there yet, but your Part D drug coverage can be included in that as well, all under one card, all under one provider. Now, with Advantage plans, they vary based on where you live and actually by zip code. So in some areas, like here in Pennsylvania, we have quite a few Medicare Advantage plans. And again, depending on where you live in the state, some areas of the state have more than 100 Medicare Advantage plans available to somebody in a certain zip code. When you get to maybe a more rural area, those could be less. Maybe, again, here in Pennsylvania on the low end, there might be 60 to 70 Advantage plans in some of our more rural areas. And again, depending on where you live in the country, that can vary as well. Some of the more rural states may have less Medicare Advantage plans available. Now, Advantage plans also encompass, or it can include, extra benefits. So what I mean by extra benefits are things that original Medicare typically doesn't cover. So Advantage plans can include things like routine dental, routine vision, hearing coverage, gym memberships, flex cards, over-the-counter cards, things that may be important to a Medicare beneficiary and could, you know, entice them to enroll in one of these plans. Now, with Medicare Advantage plans, they, like I said, are offered through private companies, and they can come with different premium costs, again, depending on where you live and what type of plan you choose. But ultimately, if you choose to enroll in an Advantage plan, you must follow the plan rules. So what I mean by that is Advantage plans tend to be, and I'm going to say the more popular types of plans out there are HMOs or PPOs or special needs plans. And things like HMOs and PPOs, they're very similar to what you may have with an employer plan. And when I say follow the plan rules, that means you would follow the plan rules on network providers, getting prior authorizations or potentially referrals for services, and then following the cost structure of that Advantage plan. And then finally, I know I just mentioned it with the Advantage plans as well, but there's also Part D. Part D of Medicare is probably the easiest one to remember. Part D is for outpatient prescription drugs, or just think D for drugs. And just like Advantage plans, Medicare Part D is offered through private insurance companies. Plans vary by state. Some states have more than others available. And each of those Part D plans has its own established formulary or set of drugs that it covers. Again, you have to follow the plan rules for the Part D plan that you are enrolling in. Just for an example, here in Pennsylvania, we have approximately like 20-ish Part D plans available. If somebody just wants a standalone drug plan, they can enroll in one of those 20 plans. Let's go ahead and go to the next slide. So we're building upon our basics here with Medicare. So now we know who could enroll, how you enroll, what's covered under Medicare. But let's talk just quickly about the options individuals have when they are new to Medicare. Or, and then we're not going to get into enrollment periods, but options they may have later on down the road if they did want to switch plans. But focusing again on somebody who's new to Medicare, when they're new to Medicare, they have some options. They can stick with original Medicare. So I keep saying that paper, red, white, and blue card. They can use that paper, red, white, and blue card with Part A and B on there as their primary insurance coverage. With original Medicare, you do have more flexibility. You have flexibility to see providers throughout the country who accept Medicare. You don't have to worry about being in network or referrals or prior authorizations. With original Medicare, somebody can build upon that basic coverage of A and B, and if they wanted to, they can add that Part D plan for drug coverage. And a lot of times individuals choose to add on something called a supplement or a supplement to Medicare, otherwise known as a Medigap policy. And a Medigap policy is its own, I want to say, animal that we're not going to get into today. But that supplement to Medicare can help fill in the gaps, or the gaps of coverage where an individual may be paying out of pocket a little bit more than they might want to, this supplemental coverage can kind of come in and fill in that gap for them. Other individuals may have other options available to them. So we do see a lot of individuals who have coverage through a former employer, like a retiree plan, or from a union, or we'll talk about it later on, they could also have Medicaid coverage. So that's one way that somebody can receive their Medicare benefits. The other way is what I, again, briefly talked about on the past slide, is Medicare Advantage. About 50%, or actually a little bit more than 50% of folks who are Medicare beneficiaries are now enrolled in Medicare Advantage plans. Medicare Advantage plans, like I said, are kind of that one-stop shop. Everything's included. You have A, B, usually D is included in there as well, plus those extra benefits. Those extra benefits make those attractive to individuals, as well as potentially having some lower out-of-pocket cost. A lot of these plans offer zero premiums or very low premiums, and the cost sharing for some services, very similar again to like an employer plan. You may just have a copay when you go to the specialist, or primary care may only be $10 or $0. So they can be very attractive to individuals for cost sharing purposes. Again, plans vary throughout the country, so you would need to take a look at what's available in your zip code area to see how many plans are available and what types of plans are offered. Like again, HMOs, PPOs, special needs plans, and there are a few other types that could also be in the Advantage plan category. Next slide, please. So let's talk about some costs with Medicare, and I'm going to divide it up between original Medicare, and then we'll focus a little bit on Advantage plans and Part D plans. But let's start with original Medicare. So I said people can use original Medicare as their primary insurance coverage, but they have to understand that that comes with some cost, and sometimes they're surprised by the costs. But let's start with Part A. So remember, Part A is that hospital portion of Medicare. For most people, Part A is free. If you've worked 40 quarters or 10 years and paid your taxes, Part A is free for you. You can also collect off of a spouse who's worked 40 quarters or more. So the vast majority of people out there don't have to pay for it. But we do encounter individuals who do not have enough quarters, and depending on the number of quarters they have, you could see on our chart here, they could pay $285 if they have 30 to 39 quarters, or $518 a month if they have less than 30 quarters. And these numbers change every year. They tend to go up every year. In addition to a Part A, if you had a premium, like I said, most people don't, but there is another cost to Part A that people, again, tend to not think about or know about, and that's the cost when you use Part A. So if you are inpatient in the hospital, Part A has a deductible. That deductible for this year is $1,676 per what's known as a benefit period. And a benefit period it's a time when you are an inpatient in the hospital and you're discharged from the hospital. And then if you haven't gone a certain period of time, like 60 days without going back in, then these benefit periods can start over. But people don't know about this. And sometimes they're surprised when they're hit with a big cost like that. In addition, there's also a cost per day if you are an inpatient. And you can see, depending on how many days you've been in the hospital, it could be $419 a day, 61 through 90 days, or it goes up $838 a day for days 91 through 150. Same with skilled nursing. So if you're in rehabilitation, you can see there's a cost per day for days 21 through 100. So you can see why people might think about adding a supplement onto Medicare or looking at another option like an Advantage plan, because these costs can add up. So in addition to our Part A costs, let's talk about Part B. Again, we use Part B probably more often than A. Part B has a monthly premium, $185 a month. That's what our costs are this year in 2025. Again, they tend to go up over time. Part B also has a yearly deductible, so it is more of a traditional deductible starting in January. $257 is our deductible this year. And I failed to put on the slide, and I'm not sure why I forgot to, but the cost sharing associated with Medicare Part B. So if somebody has original Medicare, that's what they're using, they have a, I'm going to call it a split with Medicare. So if they are using Medicare covered services under Part B, they're going to have an 80-20 split with Medicare. Medicare is going to pay 80%. They're going to be responsible for 20% of Medicare's approved amount. So again, that can add up for sure. So that's where, when we look at these other options, and I'm going to now hop to Medicare Advantage Plan or Part C, what happens with the costs associated with Part C can be a little bit different. We still have to have Medicare Part A and B, so I'm still paying those premium costs for A and B, but I have to have A and B to be able to enroll in a Medicare Advantage plan. That's kind of my ticket to get in. And if I'm in a Medicare Advantage plan, that's where, as I said before, you follow the structure of the plan. You pay the premium if there is one for the plan. If there's deductibles, co-insurance, or co-pays, that is what you are paying for or to the Medicare Advantage plan instead of those costs that are above with original Medicare. So it's kind of a way that people can potentially lower those out-of-pocket costs. But copays can add up over time, so it's something important that people look at when they're making a decision. Very similar to that with Part D, same thing. You're going to follow the structure of the plan. You're going to pay the plan's premiums, deductibles, and co-insurance amounts for whichever plan you choose. Next slide, please. So I will say that was my very brief high-level overview of Medicare. We could get into so much more, but we want to have time to talk about the cost sharing or the programs that help with Medicare cost sharing here in a few slides. But I wanted to mention that if you do have questions about Medicare or need help understanding Medicare, or you have a client that wants to talk to somebody about Medicare, I urge you to contact your state health insurance assistance program, otherwise known as a SHIP. Every state has a SHIP program. It may not be called a SHIP where you are at. Every state has the option to name it something else. Here in Pennsylvania, our SHIP is called PA Medi. But you can see on the screen, and it's also there in the chat, you can find your SHIP by going to the website listed or calling, and they can direct an individual to their local SHIP program where they could meet in person or over the phone with a counselor who can talk them through the different aspects of Medicare. And the really great thing about the SHIP programs is they are unbiased. They don't sell anything. They don't sell products. They're there for education and counseling purposes. Next slide, and I am going to be turning it back over to Katie.
Thanks, Jess. And the SHIPs provide free help, which is always always nice. So we heard all that great information from Jess about Medicare, and Medicare provides really good coverage, but it is also very expensive. All of those costs that Jess went over can very quickly add up. So we included this information to show that a lot of people on Medicare do not have a whole lot of money. These graphics reflect data from 2023. The first map on the left shows the percentage of Medicare beneficiaries with income below 100% of the federal poverty level in each state. And the map on the right shows the percentage of Medicare beneficiaries between 100 and 199% of the federal poverty level. Overall, in 2023, 13.7% of the Medicare population in the U.S. had income below 100% of the federal poverty level, and 18.8% had income between that 100 and 199% of the federal poverty level. So this works out to over 19 million Medicare beneficiaries nationwide with incomes below 200% of the federal poverty level. For reference, in 2023 that 100% of the federal poverty level was about $12.15 a month. So it's important to understand the programs that can help people with lower incomes with their Medicare costs. Next slide, please. All right, and we'll get into those programs. Can you skip to the next slide? So we thought we would illustrate this through a common case scenario. So here we have Lynn. Lynn is 66 years old. Her spouse passed away last year, and since then she has been struggling financially. She was used to having 2 incomes in her household to meet their needs, and now Lynn has a gross income of approximately $1,500 a month. And only has about $8,000 left in savings, but that amount is dwindling as she needs to pay for property taxes or when she needs a home repair. In addition to her regular bills, Lynn is also paying over $300 a month for her health insurance premiums for Medicare. After paying her bills, she has very little money left over for food and gas for her car. So Lynn has come in, you sit down with Lynn to go over her health insurance costs. Lynn has original Medicare. Her Part B premium is coming out of her Social Security check each month before it's deposited. She's also paying for a Medicare supplement, a Medigap that Jess talked about, and that is $130 a month. And finally, Lynn has a Medicare Part D plan with a $40 per month premium. So she's having difficulty affording all of her premiums along with the rest of her bills. So we're going to follow Lynn as we go through these programs to discuss how these programs might help ease some of her costs. Next slide, please. And actually, you can go ahead and skip forward. Thank you. So we're going to start our discussion with the Medicare Savings Programs. These programs are sometimes referred to as Medicare buy-in programs. Of course, all these programs have more than one name. We can't be simple. We have to make it complicated and give more than one name for these programs. But what are the Medicare Savings Programs? These are Medicaid programs. So I'll start by saying we're familiar with Pennsylvania's Medicare Savings Programs, but each state has Medicare Savings Programs, but they might look a little different in each state. This is a program that primarily helps Medicare beneficiaries with lower incomes pay their Medicare Part B premium. It is a Medicaid benefit, as I mentioned, and that means that someone seeking assistance through these programs needs to meet all of the normal Medicaid requirements, residency in the state, immigration status, and then meet the income and resource limits to qualify for that program. The primary benefit that people receive through this program is help with their Medicare Part B premium. As we mentioned, the Part B premium in 2025 is $185 a month, so that's a really big benefit. People with the very lowest incomes can also get help with their Medicare Part A premium if they have one, and also with their Part A and B deductibles and cost sharing. One other really great benefit of the Medicare Savings Program is it can help people who qualify enroll in Part B without a late enrollment penalty. So Jess didn't get into Medicare's enrollment periods, but there are specific times when you can enroll in Medicare. That's one of the ways that Medicare is different than Medicaid. With Medicaid, you can enroll at any time. With Medicare, there are specific enrollment periods, and if you miss an enrollment period, you can get hit with a late enrollment penalty that then sticks with you and adds to that Part B premium every month. So if you qualify for the Medicare Savings Program, it allows someone who qualifies to enroll in Part B at any time of the year and eliminates any late enrollment penalty. And that remains true even if the person later loses eligibility for the program. The late enrollment penalty is eliminated by qualifying for this program. So if you're working with someone who doesn't have Medicare coverage and they waited to enroll and want to enroll but are worried about the late enrollment penalty, it's worthwhile to see if they qualify for this program. I will say not everyone with Medicaid gets this help. This is a common point of confusion that people think, oh, if I have Medicaid and I'm Medicare eligible, I'll get help with the Part B premium. This is a separate category of Medicaid, and you always have to meet the income and resource limits to qualify for this program. Next slide, please. All So just to highlight why the Medicare savings programs are so important, certainly they're giving people more money in their check each month so they can pay their other expenses. Jess is going to talk about the Extra Help program that helps people with their prescription drug costs, but getting enrolled in the Medicare Savings Program automatically qualifies someone for extra help. And we know that many people don't know about this program or just need help applying. We often hear from people who have had a change in circumstances, like Lynn. Maybe they applied in the past, they didn't qualify, and then they've stopped working, their spouse has passed away, or they've spent down their savings, and now they do qualify. Next slide. Okay. So the requirements to qualify for the Medicare savings programs are simple and straightforward. You need to be on Medicare or be eligible for it and meet the income and resource limits. So this chart that we've provided here lists the income and resource guidelines in 2025 in Pennsylvania. Since this is a Medicaid program, it's going to be state specific. Pennsylvania follows the federal income and resource limits for the Medicare savings programs, but states are allowed to be more generous. And we know that several states either have no resource limit or have a higher resource limit than the federal minimum reflected in Pennsylvania. And some states also have higher income limits for these programs. So, and we know some states also call these categories something different or have additional categories. Just remember that not all income and resources count toward these limits, and what counts may also vary a little bit from state to state. But generally, the Medicare Savings Program follows the SSI rules. The first $20 of your unearned income per month doesn't count, and only about, if you're working, only about half of your earned income counts toward these limits. Typically, your house doesn't count as a resource, one vehicle. In Pennsylvania, if you have burial plots, prepaid burial reserves, or life insurance, there are pieces of that that don't count toward these limits. Next slide, please. I wanted to review briefly the benefits people can receive through the Medicare savings programs. The QMB qualified Medicare beneficiary category for people below 100% of the federal poverty level. The state pays your Part B premium and your Part A premium if you have one. And someone in the QMB category also gets assistance with their Medicare cost sharing. In Pennsylvania, that's through your access card. This is a really powerful category too because it comes with some very specific billing protections. Medicare providers aren't allowed to balance bill qualified Medicare beneficiaries for Medicare Part A and B covered services under any circumstances, and can actually be sanctioned if they do. So sometimes we do hear from people who have been balance billed their QMBs and they shouldn't have been. And people can contact Medicare and complain about a provider if they're balance billing, or sometimes other legal aid programs can help. We'll reach out to providers at times to say, hey, you shouldn't have billed this person. Did you realize they're a QMB? And can get that taken care of. People in the SLIMB category get help with their Part B premium. If they qualify, they can also have full Medicaid in another category. And then people in the QI1 category under 135% of their federal poverty limit get help with their Part B premium. They cannot also have full Medicaid and be in this category. So sometimes that's a challenging area for advising people. And people don't have to apply for these individual categories. They just go to their state Medicaid office, apply for the Medicare Savings Program, and that gets worked out on the back end. The Medicaid office determines which category people fall into. And then once you're approved, your Part B premium should stop coming out of your Social Security check, and any premiums paid since your eligibility date started should be refunded to you by Social Security. Next slide. So let's take a look back at Lynn and see how the Medicare Savings Program could really help someone in her situation. Based on the income and resource information she provided, it looks like Lynn qualifies for the Medicare Savings Program, most likely in the SLIMB category. So if this is the case, Lynn would no longer have to pay her Medicare Part B premium. The state would take care of that payment for her. And with that, her monthly out-of-pocket healthcare premium costs will drop by $185 a month. So I wanted to pause here to see if we have any questions, and then I'll turn it over to Jess. Okay, I did see one question that does SSDI count toward the limit? Yes, at least in Pennsylvania, all but $20 of that would count toward the limit, and I suspect it's probably the same in other states. All right, I'll turn it over to Jess.
Thank you. I'm ready for the next slide. So we are going to move into another assistance program that can help with Medicare cost. It's Extra Help, and that helps with prescription drug costs. So let's go ahead. We'll move on. Thank you. So what is Extra Help? And that's always a good question, right? So as Katie had said, I feel like all of these programs have multiple names, right? Extra Help is what we tend to call it. It's a very nice, easy way to say low income subsidy, or LIS. So that is the other term for this program. This is a Medicare benefit. It's a federal benefit. It can travel with people throughout the country since it is a Medicare and a federal benefit. What Extra Help does is it helps with Medicare Part D costs. It can help an individual who qualifies lower or eliminate a Part D premium. It will get rid of any deductible associated with a Part D plan, and copays for their prescription drugs are lowered significantly, or in some cases, they could also end up being $0, which we will talk about in a few slides. And just like with the Medicare Savings Programs, if somebody had a late enrollment penalty with Medicare Part D, and they qualify for Extra Help, that penalty again would be wiped away. So it is very helpful in those circumstances when you've had an individual who maybe didn't enroll in Part D because they didn't want to pay the cost, or they didn't take medications at the time and they didn't think they needed it, and now they're stuck with this penalty. If they qualify, it goes away. The program itself is administered by Social Security and CMS. Social Security is the one that takes the applications, processes them, and provides the award notification. And then CMS gets that data and is able to apply it to the Medicare beneficiary's record. Next slide, please. So again, very similar to the Medicare Savings Programs. It's always important to talk or list why these programs are important to individuals. So why is Extra Help important to a Medicare beneficiary? Well, Medicare Part D can be very expensive if somebody has expensive medications. They have to pay a premium, deductible and cost sharing for those medications, and that can add up over time. So Part D was created back in 2006, and that's when Extra Help was put into place for individuals who have limited income and resources to help afford their Part D costs. And moving forward with Extra Help, it's important to remind people that it's available. Just like Lynn in our case scenario, Lynn's situation changed over time. So previously, she might have not been available. With her income changing, she may now be available or eligible for this program moving forward. And every day from now until 2030, there are 11,000 people becoming Medicare eligible. So those individuals may not know this program exists, and it could really help them, again, afford their medication costs moving forward. Next slide, please. So let's focus on what it looks like when somebody has Extra Help versus what it looks like if somebody doesn't have Extra Help under Medicare Part D. So in 2025, if somebody has Medicare Part D and they qualify for Extra Help, they are going to receive 100% premium subsidy up to what is known as a regional benchmark. And a regional benchmark is what CMS states is basically the average cost of a Part D plan in specific areas of the state. I did a little research before our presentation. On the low end in New Mexico, the regional benchmark is $15.83. On the high end in the state of New York, it's $72.34. So that's a really wide range of costs there. Here in Pennsylvania, our benchmark is right around $48. So if I qualified for extra help, I would have a subsidy up to $48 here in Pennsylvania. And there are some plans that are called benchmark Part D plans that if an individual qualifies for extra help, those Part D plans would cost them nothing. So here in Pennsylvania, for example, again, we have 2 of those benchmark plans. But extra help doesn't just necessarily have to tie into a standalone Part D plan. If somebody has an Advantage plan, it can also be part of that help with the cost and the premium of that Advantage plan and help pay down that premium for somebody, again, up to the regional benchmark. If I don't have extra help, well then I'm stuck paying the plan premium for whatever plan I have chosen. On the deductible side, if I have extra help, I don't have a deductible. If I don't have extra help, excuse me, then I would be stuck paying up to $590, which is the standard deductible here in 2025. Now we'll get into the cost of the medication. So if I do have extra help, my cost can vary depending on what level of medical assistance I may have, or if I don't have medical assistance, or kind of my setting of where I'm residing. So our first category here with the $1.60 for generics and $4.80 for brand names, that is for individuals who have full medical assistance. They will be at this lower cost sharing level with their drug costs. The second level, the $4.90 and $12.15, that's where our folks that Katie was talking about, our people, our partial duals, individuals who have help with their Medicare Part B premiums, for example. They have a little bit higher of a cost sharing for their drugs. And then we also have those folks who just have extra help. They don't get any other type of assistance. They fall in that category. Then we have our individuals who have Medicaid that's long-term care Medicaid. So they're in a nursing home or they're on a long-term care waiver. Those individuals, their drug cost with extra help are $0. And I do want to just add to this note about the drugs here. It's important to remember that to get these costs, the drugs have to be on the plan's formulary. If the drugs are not on the formulary, then they could either be stuck paying, obviously a lot more out of pocket for that drug because it's not covered, or they would have to go through the process of getting that drug covered on their plan's formulary. If they don't have extra help, they're stuck with the standard cost for 2025. That's really 25% of your co-insurance. We're usually in a copay type situation until somebody reaches $2,000 in their out-of-pocket drug costs. Again, usually it's a tier structure with copays. And then for both groups, whether you have extra help or not, if you reach what's called catastrophic coverage, then you pay nothing for the rest of the calendar year. So you can see how extra help could really be beneficial for an individual in affording their drug costs. Next slide, please. So who qualifies for extra help? And this slide's important because there are categories of individuals who don't need to do anything. They're going to get extra help automatically. And those are our individuals who are receiving any type of Medicaid benefit. They could have full medical assistance, or they could just be receiving the Medicare Savings Program and just having their Part B paid for. In those circumstances, they don't need to do anything. It will automatically happen. They will get that extra help benefit. No application is needed. For anybody else out there, if they want to apply for extra help and they're not getting Medicaid benefits, they would do that through Social Security. Quickest and easiest way is online, Social Security's website. There's an application right on there that you can do. And once you're done, it will be processed. And again, that is the quickest way. There are options to get paper applications through Social Security, which can take a little bit more time. You can also work with your state health insurance assistance program, and they can also help with that application process as well. Now, of course, in order to qualify, you must meet income and resource guidelines, which we'll go ahead and switch to the next slide. And you will see those income and resource guidelines for 2025. Again, they do change every year. The income and resource guidelines are slightly higher than the Medicare Savings Programs that Katie had talked about. But again, not all income and resources count towards those limits. So we do have our single and our married structure here. If you have questions about that, we can feel free to answer those later on. Let's go ahead and go to that next slide. All right. So let's talk about applying for extra help. There is no time frame to apply for extra help. If somebody needs to apply, they can do it at any time. Just go online and do that application. You don't even need to have Medicare Part D to apply. Just go on, do it, get it processed or started in that processing. So hopefully the individual will be awarded the benefit and can move on with Part D. Again, remember, and you're going to see this several times in our slides, that if they are already getting those Medicaid benefits, they don't need to do anything. They will automatically get this extra help. It's tied in to having those specific Medicaid or those Medicaid benefits. We do have on the screen here a link where you can go to Social Security and apply. You can even just go to ssa.gov and you'll see a section that says Medicare, and you can click on that and it will give you information about extra help. The phone number for Social Security is on here. And again, you can request a paper application. It's kind of a Scantron type paper, so no photocopies of that are accepted. But once somebody applies, their application will be reviewed by Social Security. You don't need to send any other documentation in. You're attesting to what you put on the application. If something looks off, Social Security may contact you for some additional information, but usually what is in there should be sufficient. And once it's processed, the individual will get a notice whether they are approved for extra help or if they are not approved. And if they're not approved, they can always, appeal that decision. But if somebody is approved for extra help benefits, that data would be transferred over to Medicare. And if they're already in a Part D plan, it will be applied to that Part D plan. Or if they're not in a Part D plan, they will have the opportunity through a special enrollment period to enroll in a Part D plan. Or if they do nothing at all and they just are awarded extra help, eventually Medicare will auto enroll them into a Part D plan. So let's move to the next slide and talk about what income counts or what extra help looks at on the income side of things. Social Security benefits, railroad retirement, pensions, wages, VA benefits, alimony, spousal support, unemployment, workers' comp, those all count as income. But very similar, again, to what Katie had mentioned, not all income is counted. So they use those same rules with the unearned income, where there's a $20 a month exclusion from the unearned income. And then earned income, again, they're only going to count about half of that unearned income, or excuse me, earned income towards calculating your eligibility for the benefit. So oftentimes people say, I'm way over and they're working. I really would urge them to look at that again, because they may be, on the face of it, look like they're over the income and resource guidelines. But with some of these exclusions, they may actually be eligible for the program. So let's take a look at the resources on the next slide. So very similar again, things like bank accounts, stocks, bonds, mutual funds, retirement accounts, properties outside of the one that you are residing in, your primary residence, cash on hand at home, annuities, certain trusts. But what doesn't count, your primary residence. Different from the Medicare Savings Program, all vehicles don't count. Life insurance does not count, burial plots, irrevocable burial accounts, your items in your home. And then there is also an exclusion if somebody is going to be using some of their resources towards funeral or burial purposes of $1,500 per applicant. So let's do that next slide. Okay. So again, just to reiterate a few points here, applying for extra help, again, apply online. That's the fastest way. And if you do that, you are able to print a copy of what you put in the application. If you aren't finished, you can re-enter and finish that later on with a re-entry number. Again, no verification is required on the back end with documents needing to be submitted to Social Security. If they need something, they'll reach out and ask you. One thing that's a little different with Social Security and extra help applications, there's no time frame for processing of the applications in the rules. Again, online seems to be the fastest way to get that whole process started, and again, through the processing and getting that award notice. You will get an award letter from Social Security if you're eligible. If not, you're going to get a notice that says you're not. And of course, you can appeal, and all of those appeal instructions are within that notice. Next slide, please. So what happens after you're approved? I mentioned it very briefly. Social Security sends that information over to Medicare, and your Medicare Part D costs go down automatically. If you were already enrolled and spent some money that maybe you didn't need to, or the data wasn't processed in time when you became eligible, you could be eligible for a refund. And then again, as I mentioned, if you did not have Part D, you can enroll in a Part D plan through a special enrollment period. If you do nothing, you will be auto-enrolled by Medicare. Your extra help lasts for at least the entire calendar year, even if you win the lottery in the middle of the year. So that's a really interesting point to that. Now, notices are sent to people if they are going to automatically lose their extra help eligibility near the end of the year. And that could be for individuals who are no longer automatically eligible because they lost Medicaid benefits. Or sometimes people are chosen for a renewal by Social Security in around the August timeframe. And if they don't turn that in, then they can be sent this notice saying that they are no longer eligible as well. Now, if somebody changes their Part D plan in the middle of the year, or maybe they move to another state, or something happens related to Part D, since this is a federal benefit, this benefit would move with them. So if I changed from one plan to another, it just moves with me. Or say I move from Pennsylvania to Arizona, I still would have my extra help benefits moving with me to another state. Next slide, please. So let's apply this to Lynn. And I guess this is kind of a little bit of a trick scenario here, right? So we talked about Lynn, and now we're going to ask, does Lynn qualify for extra help? And we know that she does meet the income and resource guidelines after we took a look at her information she brought in. But if we did that application for her for the Medicare Savings Program and she qualified for that, she would automatically get the extra help benefit. So that would be tied into that. But oftentimes people say, well, if somebody's coming in and they want to apply for both, Medicare Savings Program and extra help, should I do both? It doesn't hurt to do both because one may happen before the other time frame wise in processing. So she could, do that application as well. And maybe that may be processed, before MSP or vice versa. So overall, with Lynn, just coming in and doing those screenings, as Katie mentioned, We were able to help save her $185 by applying and qualifying for the Medicare Savings Program. Doesn't have to pay Part B premium anymore. And now she's qualified for extra help. So that $40 a month premium has now gone away. And I'm not even, calculating in what she may be saving in drug costs as well. But just in those premium costs, we were able to get her down to just now having to pay $130 a month for her Medigap plan that she has, and maybe she wants to keep that Medigap policy. So that additional $225 we saved her can be used towards, gas, food, bills, whatever she needs to use that for.
And Jess, I know we have some information in the slides coming up about other programs that are
Yes.
available, a little about dual eligibility, but why don't we skip over to, just for time reasons,
Yes,
maybe we
I
could
saw.
skip over for Tia.
Absolutely. We could take questions after.
Yep.
So we'll go ahead and skip forward to Tia, just because it's 3 o'clock.
And certainly, if there's anything in the materials that we didn't get to go over that folks have questions about, at the end, you can chat them in or reach out to us individually.
All right, thank you, Katie and Jessica. Good afternoon or good morning, depending on where you're joining us from. My name is Tia Whitaker. I'm the statewide director for outreach and enrollment at the Pennsylvania Association of Community Health Centers. And I want to piggyback on some of the information that our friends at the Pennsylvania Health Law Project provided us when it comes to assisting Medicare eligible populations. Next slide, please. Our community health centers are changing lives every single day, and it's our honor to serve and support them statewide. Next slide, please. Just some information about our community health centers in Pennsylvania. We serve more than 1 million people annually in Pennsylvania at 54 health centers at more than 440 sites in our 55 out of 67 counties in Pennsylvania. And we provide more than 3.1 million visits annually and contribute millions of dollars to the economy and to local communities. Next slide, please. So just so you get an understanding of our state, as you can see, we have 2 maps. One shows the rural and urban counties, the designation, and then the other map shows where our community health centers are located across the state. Next slide, please. So when speaking about the Medicare populations, at some point in our lives, we will come in contact with or take care of or become a senior. So as many people across this state, we're here to serve. Our Medicare eligibles and those who are in our senior populations are extremely important. So as you can see, the total Medicare enrollee across the nation, our Pennsylvania Medicare enrollees are 2.8 million, which is 17% of the population. And then nationally, health center Medicare patients are over 3 million. And here in Pennsylvania, our Pennsylvania Health Center Medicare patient population is about 13%. Next slide. So as with this webinar, we are excited to partner. That's one of the things that we do, and I think we do it well. At PAC, our Pennsylvania Association of Community Health Centers, we partner with the Pennsylvania Department of Aging, the PA Medi program, which our partners talked about a little bit earlier, Pennsylvania Medicare Education and Decision Insight, and then also the Pennsylvania Health Law Project. Through our partnerships, we're able to reach Medicare beneficiaries and our senior population across the state through many programs. the state health insurance program, and specifically with our health centers, we work through the Medicare Improvement for Patients and Provider Act, providing enrollment assistance specifically to those Medicare eligibles who are eligible for the low income subsidy and Medicare Savings Program. We also refer many Medicare eligibles to our PA Medi program, where they're able to access benefits and information through our 52 local area agencies on aging. And then, of course, our Pennsylvania Health Law Project, who we love dearly and we partner with all the time for training and technical assistance and assistance with complex cases. Next slide, please. So specifically, we have about 135 certified marketplace health center enrollment assisters. And those are folks who are able to enroll recipients or patients into our health insurance marketplace, which is called Penny. We also have 70 trained Medicare low-income subsidy Medicare Savings Program health center enrollment assisters to provide that enrollment assistance to our Medicare population and our senior patients, helping them to navigate the waters of health insurance, specifically when it comes to Medicare and accessing those benefits and savings. And in previous years, we have screened nearly 200 eligibles for those extra help and Medicare savings programs. So when we have folks who come into our community health centers, not only are we providing them with quality healthcare, dental, and behavioral health services, we're also screening them and assisting them with screening for health insurance. And the Medicare Savings Program and the extra help programs are extremely important when it comes to that population. Next slide, please. So I wanted to talk a little bit about the process when it comes to enrollment assistance. At our health centers, we work through workflows and through referrals when it comes to our outreach and enrollment. So our outreach is from outside of our four walls into the community where we experience and where we may run into those who are eligible for Medicare and for the extra savings programs. We also do in-reach. We utilize the tools that we have in-house through our EHRs, through visits, through referrals, through people who are coming in to let them know that they may be eligible for additional savings. So we know and provide information on Medicare and the Medicaid programs because we all understand that the systems can be very complex. And folks, in Pennsylvania, we have what we call no wrong door. So if you come in through one agency or come in one way, we're able to refer you directly to the next agency or to the next person, or we don't necessarily have to do a warm handoff. We have enrollment assisters who can walk you through the process. We also collect demographic information to make sure that we're collecting information on the correct folks and making sure that they're getting directly into the programs that they need to be in. We assess for program eligibility, enroll and complete applications, which can be cumbersome sometimes for our senior and Medicare population. So we're walking them through the process. We document in our EHRs and in the STAR system, which is from the Department of Aging, to collect the demographic information on our seniors so that we can reach out to them directly about the programs. We also track and follow up. There's nothing worse than giving your information to someone, trusting them, and then not hearing from them again. So our enrollment assisters provide that enrollment assistance, but they track and they follow up with each individual. Next slide, please. So the enrollment assistance that we provide with Medicare, all of the parts that we talked about earlier. Medicaid, for those who are new to Medicare, we provide education and links to understand what it means to be Medicare eligible. We also assist with transitioning from marketplace to Medicare, which can be a tricky process. We also provide information and links to TRICARE benefits, VA health benefits, and also other programs like the PACE program. Next slide, please. So our goal really is to help our seniors obtain the security of health insurance coverage. There's nothing worse than thinking you have the information that you need or have the help that you need and realizing at the critical moment that you don't. So our enrollment assistants at our community health centers really are poised and ready to ensure they're able to walk our seniors and Medicare eligibles through the process. We assist seniors with lowering their healthcare costs and making those vital connections through our partners. We connect the seniors to needed care as well. Once they come into our community health centers, we're looking at the whole person. So they're able to get the services that they need and get linked to those services in a one-stop shop. So we open the door to other services as well. It's medical, behavioral, dental, and a myriad of other services that are available at our community health centers, specifically for our Medicare population. And also our goal is to improve health-related outcomes. And we see those time and time again with statistics that identify for seniors and for individuals who are coming into our health centers, if they are connected with a primary care provider and with other what we call enabling services. Those are folks who provide enrollment assistance, who do assist with transportation and translation and case management. We've seen those health outcomes increase significantly. Next slide, please. Do we have any questions?
We do. One of the things we want to do while we still have members of the audience here and some time, I'm hoping we can run that second poll, and then we'll have Aubrey pose one of the questions from the slides on duals. But are there any questions for Tia, who we know her audio was a little choppy, but it sounds like people could hear her. So sorry about that, y'all. Let her know if you have any questions about the work that they do at the Pennsylvania Association of Community Health Centers. But let's go ahead and launch that poll that we had up on the screen, poll number 2. So will the Medicare information from today's presentation be helpful in your work? As folks are responding, we'll scroll back to the poll, the section that Kitty and Jessica were presenting on, and bring up on the screen the why is understanding dual eligibility important, and ask for some input from Katie, Jessica, and Tia about the duals and why it's really important to understand. So one more forward, Reha, and then we'll close out the poll. Just go one slide forward, Reha, and then we'll close out the poll. All right, let me read out polling responses here for our panel to help you on that. The audience is actually saying yes, this has been very helpful, that they'll be able to use Medicare information from today's presentation in their work, somewhat helpful, not quite sure yet, and not surprised because Medicare is really complicated. We usually, when we are talking in the MLP space about coverage, we're typically talking about Medicaid. So yeah, this will definitely be helpful in our training and technical assistance work as well. And we're really glad to hear from the audience that it'll be helpful in your day-to-day work. Just so folks know, the Pennsylvania team presenting today actually do this as an almost day-long training, if not multiple days. And so they condense a lot of information, cut out some of the hands-on content to present it on today's webinar. So with that, I want to pass it back to Aubrey to pose a question to the audience. And Reha, if you could scroll forward to the why is understanding dual eligibility important slide. Let's leave it on the screen while Aubrey presents that. Perfect. Thanks.
Yeah, so as Bethany said, I will pass it back to Katie and Jessica to talk about why understanding dual eligibility is important.
Yeah, and I can speak to that a little bit. I think, Jessica gave a brief overview of Medicare, and even that was fairly complicated. And I think many of you know Medicaid probably better than Medicare, as I do. You know, my primary work is with Medicaid, and Medicaid is also super complicated. So people with both Medicare and Medicaid have really good insurance. They have very complete coverage, but they have to then navigate these two very bureaucratic and complicated systems. So what we often see, we hear from at the Health Law Project, a really high number of dual eligibles who are just really confused about their coverage. Transitions for this population can be really confusing for people who have Medicaid and then become Medicare eligible, and and dual eligible means you have both Medicare and Medicaid. So for people with both of those insurances, they know they have multiple insurance cards in their wallet, but may not understand how those insurances work together. This tends to be a sicker, I would say, population, a high cost and high need population. And there's a whole lot of dual eligibles nationwide. I have on the slide 500,000 approximately in Pennsylvania, 12 million nationwide. But, for folks who had Medicaid, for example, and then become Medicare eligible, Medicaid covers typically 100% of your prescription drug costs. You switch to becoming Medicare eligible, you still have Medicaid, but now it's Medicare covering your prescriptions. Now you have copays, which can be really challenging for people to afford, even when they're the small extra help copays that Jessica went over. So, and just if you move forward to the next slide, Reha. We have a little bit there about just understanding for people who have both Medicare and Medicaid. Medicare is their primary insurance. Medicaid is always the payer of last resort. Medicaid follows Medicare, but Medicare is going to be your primary coverage for most health services. Medicaid tends to provide broader coverage even than Medicare does. So for people who have Medicare, Medicare doesn't provide dental coverage. There's no vision coverage. It may not cover incontinence supplies, original Medicare in particular. And those are things that Medicaid may cover. And so having those two insurances can be helpful. I generally encourage people, just if you're going to the doctor or the pharmacy, just pull out all those insurance cards in your wallet, lay them all on the table, because often we find that people don't quite know what they have. They'll mention, oh, I have this insurance company or that one, but they're not sure, what's Medicaid, what's Medicare necessarily.
And also, when we're meeting with Medicare eligible patients or consumers at our community health centers, we want to make sure we have all of the information available for them so we can direct them to the best possible plan, to the best possible program, to all of the things that they need to ensure that they don't slip through the cracks, to ensure that they have all of the information.
And going a little further, do you, and this is for anyone on the panel, do you have any tips for staff working with veterans on these issues? Jessica?
Yeah, I was just thinking about that. And with veterans, depending on the veteran's status, right? So if they are somebody that may go to the VA for services, I think a lot of times with individuals who fall into that category, they may not think about Medicare too often. They may be getting all of their services through the VA, but it's important for them to think about Medicare when they become Medicare eligible and think about, you know, what options they have on that Medicare coverage side, because sometimes we do have folks that are veterans who say, I don't need Part B because I go to the VA for everything, and they don't sign up for it. And then what happens down the road is they need to see a provider outside of the VA, and they may be stuck not having Part B and then, having difficulty enrolling. So if they're not wanting Part B because they go to the VA for everything and they don't want to pay for it, look at the Medicare Savings Program, because they may be eligible and they could have Part A and Part B. And again, really have some, I'm gonna say, complete care, especially if they are going to the VA for everything. But I think it's very important for veterans to talk to their state health insurance assistance program about that, because they want to make sure that they have all of their bases covered.
So, as we're starting to wrap up, and this has been a ton of information, and we've had some great information coming through the chat as well. For each panelist, what is one thing that you would want those watching either now or watching the recording later want to make sure that they got from this presentation?
From the community health center aspect, I would encourage folks to work with your local community health center. You can go on the Bureau of Primary Health Care to find a health center here in Pennsylvania on PAC.org, which is our website. There's a link that says Find a Health Center. And there are so many health centers across the state that can help with these programs and connections to many other programs.
Yeah, and I would say just taking away the knowledge that there are programs available to help people and that people's circumstances change. We know that's why a lot of people don't end up enrolled in some of these programs. They may have applied at one time, didn't qualify, or just didn't know about them because, we certainly talk to people who had higher incomes or higher resources at one point. They just weren't familiar with the Medicaid system or they never had to access it. And just may not be aware of these programs that can help with Medicare costs. And even, we have in the materials information about state pharmaceutical assistance programs. There's other programs that your state might have as well that we just didn't have time to get into that can also provide benefits or may not have resource limits. There's lots of programs and help available that we want to make sure people are taking advantage of.
I would agree with that. There are resources out there. And I think that timing when either people are new to Medicare or that transition time when they are now becoming a dual is so confusing. Lots of things could happen where, their data systems may not be working appropriately together. But there are resources out there. Reach out. And sometimes I feel like folks who are under the age of 65 may not be fully aware that SHIPs are available to everybody, regardless of your age. As long as you are Medicare eligible, they are there to help guide you through that process.
Thank you. Thank you. Those are all great points. I think this is the point where I'd like to thank everybody that participated, both those on the panel and those people watching. It was a delight to learn from everybody. There was some great information coming through the chat, as well as on the slides and from the panel. As a reminder, please take 2 to 3 minutes to respond to the post-session evaluation survey. It may not seem like much, but it makes a huge difference in helping us plan and shape future events. And we'd love to stay connected with you. So please look for us on Blue Sky and LinkedIn. Be sure to follow the National Center for Medical Legal Partnership, and so you can get those updates, resources, and learn about future events. And if you haven't already, please sign up for our newsletter to get the latest news and insights delivered right to your inbox. You'll find the links in the chat. And we also have some information about our upcoming events and trainings. Check that out on the slide. Thank you to Katie, Jessica, and Tia for an informative session today. I know I personally learned a lot, and I'm sure those poll numbers, if we ran it again, would be different from the poll we ran initially. And a special thank you for all that participated. We appreciate your time today. Goodbye, everybody.
Thank you.